Vertebrobasilar dissection. Vertebrobasilar dissection may result from sudden rotation or flexion, extension of the neck, chiropractic manipulation, or a direct blow to the neck. Common symptoms are neck pain, headache, and brainstem stroke or SA. The risks and benefits of aspirin therapy are unclear when a vertebral dissection extends intracranially. The theoretically increased friability of the vessel wall may increase the risk of SA when coupled with an antiplatelet agent. Consultation of a stroke neurologist is recommended in this situation. Brain death. Brain death occurs when there is an absence of signs of brainstem function or motor response to deep central pain in the absence of pharmacologic or systemic medical conditions that could impair brain function. Clinical examination. A neurologist, neurosurgeon, or intensivist generally performs the clinical brain death examination. 2 examinations consistent with brain death 12 hours apart, or 1 examination consistent with brain death followed by a consistent confirmatory study generally is sufficient to declare brain death. See following paragraphs. Hospital regulations and local laws regarding documentation should be followed closely. Establish the absence of complicating conditions before beginning the examination. The patient must be normotensive, euthermic, and oxygenating well. The patient may not be under the effects of any sedating or paralytic drugs. Documentation of no brain stem function requires the following: non-reactive pupils, lack of corneal blink, oculocephalic doll's eyes, oculovestibular cold calorics reflexes, and loss of drive to breathe apnea test. The apnea test demonstrates no spontaneous breathing even when PACO is allowed to rise above 60 mmHg. Deep central painful stimuli provided by bilateral forceful twist and pinch of the supraclavicular skin and pressure to the medial canthal notch. Pathologic responses such as flexor or extensor posturing are not compatible with brain death. Spinal reflexes to peripheral pain, such as triple flexion of the lower extremities, are compatible with brain death. Confirmatory studies are performed after a documented clinical examination consistent with brain death. A study consistent with brain death may obviate the need to wait 12 hours for a second examination. This is especially important when the patient is a potential organ donor, as brain-dead patients often have progressive hemodynamic instability. Lack of cerebral blood flow consistent with brain death may be documented by cerebral angiography or technetium radionuclide study. A to and fro pattern on transcranial Doppler ultrasonography indicates no net forward flow through the cerebral vasculature consistent with brain death. An electroencephalogram EEG documenting electrical silence has been used, but generally is not favored because there is often significant artifact which impairs interpretation. Spine trauma. The spine is a complex biomechanical structure. The spine provides structural support for the body as the principal component of the axial skeleton while protecting the spinal cord and nerve roots. Trauma may fracture bones or cause ligamentous disruption. Often, bone and ligament damage occur together. Damage to these elements reduces the strength of the spine and may cause instability, which compromises both supportive and protective functions. Spine trauma may occur with or without neurologic injury. Neurologic injury from spine trauma is classified as either incomplete or complete. If there's some residual motor or sensory neurologic function below the level of the lesion, as assessed by clinical examination, the injury is defined as incomplete. A patient with complete neurologic dysfunction persisting 24 hours after injury has a very low probability of return of function in the involved area. Neurologic injury from spine trauma may occur immediately or in delayed fashion. Immediate neurologic injury may be due to direct damage to the spinal cord or nerve roots from penetrating injuries, especially from stab wounds or gunshots. Blunt trauma may transfer sufficient force to the spine to cause acute disruption of bone and ligament, leading to subluxation, which is a shift of one vertebral element in relation to the adjacent level. Subluxation decreases the size of the spinal canal and neural foramina and causes compression of the cord or roots. Such neural impingement can also result from retropulsion of bone fragments into the canal during a fracture. Transection, crush injury, and cord compression impairing perfusion are mechanisms leading to SCI. Delayed neurologic injury may occur during transportation, examination of an improperly immobilized patient, or during a hypotensive episode. The mechanics of spine trauma. Trauma causes a wide variety of injury patterns in the spine due to its biomechanical complexity. A mechanistic approach facilitates an understanding of the patterns of injury, as there are only a few types of forces that can be applied to the spine. Although these forces are discussed individually, they often occur in combination. Several of the most common injury patterns are then presented to illustrate the clinical results of these forces applied pathologically. High levels. Flexion, extension, bending the head and body forward into a fetal position flexes the spine. Flexion loads the spine anteriorly, the vertebral bodies, and distracts the spine posteriorly, the spinous process and interspinous ligaments. High flexion forces occur during front-end motor vehicle collisions and backward falls when the head strikes first. Arching the neck and back extends the spine. Extension loads the spine posteriorly and distracts the spine anteriorly. High extension forces occur during rear-end motor vehicle collisions, especially if there is no headrest. Frontward falls when the head strikes first, or diving into shallow water. Compression, distraction force applied along the spinal axis. Axial loading compresses the spine. Compression loads the spine anteriorly and posteriorly. High compression forces occur when a falling object strikes the head or shoulders, or when landing on the feet, buttocks, or head after a fall from height. A pulling force in line with the spinal axis distracts the spine. Distraction unloads the spine anteriorly and posteriorly. Distraction forces occur during a hanging, when the chin or occiput strikes an object first during a fall, or when a passenger submarine's under a loose seatbelt during a front-end motor vehicle collision. Rotation force applied tangential to the spinal axis rotates the spine. Rotation depends on the range of motion of intervertebral facet joints. High rotational forces occur during off-center, impacts to the body or head, or during glancing automobile accidents. Patterns of injury. Certain patterns of injury resulting from combinations of the previously mentioned forces occur commonly and should be recognized during plain film imaging of the spine. Always completely evaluate the spine. A patient with a spine injury at one level has a significant risk for additional injuries at other levels. Cervical. The cervical spine is more mobile than the thoracolumbar spine. Stability comes primarily from the multiple ligamentous connections of adjacent vertebral levels. Disruption of the cervical ligaments can lead to instability in the absence of fracture. The mass of the head transmits significant forces to the cervical spine during abrupt acceleration or deceleration, increasing risk for injury. Jefferson fracture. A Jefferson fracture is a bursting fracture of the ring of C1, the atlas, due to compression forces. There are usually 2 or more fractures through the ring of C1. The open-mouth odontoid view may show lateral dislocation of the lateral masses of C1. The rule of Spence states that 7 millimeters or greater combined dislocation indicates disruption of the transverse ligament. The transverse ligament stabilizes C1 with respect to C2. Jefferson fractures dislocated less than 7 millimeters usually are treated with a rigid collar, while those dislocated 7 millimeters or greater usually are treated with a halo vest. Surgical intervention is not indicated. Odontoid fractures. The odontoid process, or dens, is the large ellipse of bone arising anteriorly from C2, the axis, and projecting up through the ring of C1, the atlas. Several strong ligaments connect the dens to C1 and to the base of the skull. Odontoid fractures usually result from flexion forces. Odontoid fractures are classified as type 1, 2, or 2. A type 1 fracture involves the tip only. A type 2 fracture passes through the base of the odontoid process. A type 3 fracture passes through the body of C2. Types 2 and 3 are considered unstable and should be externally immobilized or fused surgically. Surgery often is undertaken for widely displaced fractures, poor chance of fusing, and for those that fail external immobilization. Type 1 fractures usually fuse with external immobilization only. Hangman's fracture, traditionally considered a hyperextension, distraction injury from placement of the noose under the angle of the jaw. Hangman's fractures also may occur with hyperextension, compression, as with diving accidents, or hyperflexion. The injury is defined by bilateral C2 pars interarticularis fractures. The pars interarticularis is the bone between superior and inferior facet joints. Thus, the posterior bony connection between C1 and C3 is lost. Hangman's fractures heal well with external immobilization. Surgery is indicated if there is spinal cord compression or after failure of external immobilization. Jump facets, hyperflexion injury, the facet joints of the cervical spine slope forward. In a hyperflexion injury, the superior facet can jump over the inferior facet of the level above if the joint capsule is torn. Hyperflexion rotation can cause a unilateral jump facet, whereas hyperflexion distraction leads to bilateral jump facets. Patients with unilateral injury usually are neurologically intact. Those with bilateral injury, however, typically suffer from spinal cord damage, since the anteroposterior diameter of the spinal canal is compromised by bilateral injury, leading to spinal cord compression. Figure 4211. Thoracolumbar. The thoracic spine is stabilized significantly by the rib cage. The lumbar spine has comparatively large vertebrae. Thus, the thoracolumbar spine has a higher threshold for injury than the cervical spine. A 3-column model is useful for categorizing thoracolumbar injuries. The anterior longitudinal ligament and the anterior half of the vertebral body constitute the anterior column. The posterior half of the vertebral body and the posterior longitudinal ligament constitute the middle column. The pedicles, facet joints, laminae, spinous processes, and interspinous ligaments constitute the posterior column. Compression fracture. Compression fracture is a compression flexion injury causing failure of the anterior column only. It is stable and not associated with neurologic deficit, although the patient may still have significant pain. Figure 4212. Burst fracture is a pure axial compression injury causing failure of the anterior and middle columns. It is unstable, and perhaps half of patients have neurologic deficit due to compression of the cord or cauda equina from bone fragments retropulsed into the spinal canal. Chance fracture. Chance fracture is a flexion distraction injury causing failure of the middle and posterior columns, sometimes with anterior wedging. Typical injury is from a lap seatbelt hyperflexion with associated abdominal injury. It often is unstable and associated with neurologic deficit. Fracture dislocation. Fracture dislocation is failure of the anterior, middle, and posterior columns caused by flexion, distraction, shear, or compression forces. Neurologic deficit can result from retropulsion of middle column bone fragments into the spinal canal or from subluxation causing decreased canal diameter. Figure 4213. Initial assessment and management. The possibility of a spine injury must be considered in all trauma patients. A patient with no symptoms referable to neurologic injury, a normal neurologic examination, no neck or back pain, and a known mechanism of injury unlikely to cause spine injury is at minimal risk for significant injury to the spine. Victims of moderate or severe trauma, especially those with injuries to other organ systems, usually fail to meet these criteria or cannot be assessed adequately. The latter often is due to impaired sensorium or significant pain. Because of the potentially catastrophic consequences of missing occult spine instability in a neurologically intact patient, a high level of clinical suspicion should govern patient care until completion of clinical and radiographic evaluation. The trauma patient should be kept on a hard flat board with straps and pads used for immobilization. A hard cervical collar is kept in place. These steps minimize forces transferred through the spine and therefore decrease the chance of causing dislocation, subluxation, or neural compression during transport to the trauma bay. The patient is then moved from the board to a flat stretcher. The primary survey and resuscitation are completed. Physical examination and initial x-rays follow. For the examination, approach the patient as described in neurologic examination earlier in this chapter. Evaluation for spine or SCI is easier and more informative in awake patients. If the patient is awake, ask if he or she recalls details of the nature of the trauma and if there was loss of consciousness, numbness, or inability to move any or all limbs. Assess motor function by response to commands or pain as appropriate. Assess pinprick, light touch, and joint position if possible. Determining the anatomically lowest level of intact sensation can pinpoint the level of the lesion along the spine. Testing sensation in an ascending fashion will allow the patient to better discern the true stimulus, as opposed to determine when it is extinguished. Document muscle stretch reflexes, lower sacral reflexes, i.e. anal wink and bulbocavernosus, and rectal tone. American Spinal Injury Association classification. The American Spinal Injury Association provides a method of classifying patients with spine injuries. The classification indicates completeness and level of the injury and the associated deficit. Figure 42-11. A. Lateral cervical spine x-ray of an elderly woman who struck her head during a backward fall. Arrowhead points to jumped facets at C5, C6. Note the anterior displacement of the C5 body with respect to the C6 body. B. Sagittal T2 weighted magnetic resonance imaging of the same patient, revealing compromise of the spinal canal and compression of the cord. Note the bright signal within the cord at the level of compression, indicating spinal cord injury. C. Lateral cervical spine x-ray of same patient after application of cervical traction and manual reduction. Note restoration of normal alignment. D. Lateral cervical spine x-ray after posterior, a form similar to that shown in Fig. 42-14 should be available in the trauma bay and completed for any spine injury patient. The association also has worked to develop recommendations and guidelines to standardize the care of SCI patients in an effort to improve the quality of care. Neurologic syndromes. Penetrating, compressive, or ischemic cord injury can lead to several characteristic presentations. Figure 42-12, A. Lateral lumbar spine x-ray showing a compression fracture of L2. Arrowhead points to anterior wedge deformity. Note the posterior wall of the vertebral body has retained normal height and alignment. B. Axial computed tomography scan through the same fracture. Arrowhead demonstrates a transverse discontinuity in the superior end plate of the L2 body. Based on the anatomy of injury, the neurologic deficits may be deduced from the anatomy of the long sensory and motor tracts and understanding of their decussations. Figure 42-15. Four patterns are discussed. First, injury to the entire cord at a given level results in anatomic or functional cord transection with total loss of motor and sensory function below the level of the lesion. The typical mechanism is severe traumatic vertebral subluxation, figure 42 to 13. Sagittal reconstruction of reducing spinal canal diameter and crushing the cord. Second, injury to half the cord at a given level results in Brown-Sequard syndrome, with loss of motor control and proprioception ipsilaterally and loss of nociception and thermoception contralaterally. The typical mechanism is a stab or gunshot wound. Third, injury to the interior gray matter of the cord in the cervical spine results in a central cord syndrome, with upper extremity worse than lower extremity weakness and various degrees of numbness. The typical mechanism is transient compression of the cervical cord by the ligamentum flavum buckling during traumatic neck hyperextension. This syndrome occurs in patients with pre-existing cervical stenosis. Fourth, injury to the ventral half of the cord results in the anterior cord syndrome, with paralysis and loss of nociception and thermoception bilaterally. The typical mechanism is an acute disc herniation or ischemia from anterior spinal artery occlusion. Studies, anteroposterior and lateral plane films provide a rapid survey of the bony spine. Plane films detect fractures and dislocations well. Adequate visualization of the lower cervical and upper thoracic spine often is impossible because of the shoulder girdle. Complete plane film imaging of the cervical spine includes an open mouth view to assess the odontoid process and the lateral masses of C1. Fine slice CT scan with sagittal and coronal reconstructions provides good detail of bony anatomy and is good for characterizing fractures seen on plane films, as well as visualizing C7, one when not well seen on plane films. MRI provides the best soft tissue imaging. Canal compromise from subluxation, acute disc herniations, or ligamentous disruption is clearly seen. MRI also may detect EDHS or damage to the spinal cord itself, including contusions or areas of ischemia. Neurologic deficit. Indications for screening for vascular injury with cervical spine trauma. It is important to consider the presence of blunt cerebrovascular injury in patients with cervical spine trauma. However, the specific indications for obtaining a screening CT angiography study are controversial. Many trauma centers rely on the Denver criteria. These criteria indicate that screening should be employed for a cervical vertebral body or transverse foramen fracture, subluxation, or ligamentous injury at any level, or any fracture at the level of C1, C3, among other indications such as concerning mechanism, Lefort mid-face fractures, or basilar fractures through. The carotid canal, a recent single-center retrospective study equal to 1,717 cervical spine fractures, found a higher risk of vertebral artery injury only in the setting of fractures of C1 and C2 combined. Those that involved the transverse foramen or had significant subluxation, they did not find that high-risk cervical spine fractures as defined by the Denver criteria were associated with an increased risk of blunt cerebrovascular injury. Based on these data, we feel that it is appropriate to use a more defined set of screening criteria as outlined by Lockwood et al. To reduce cost and contrast exposure in patients with cervical spine fractures. Definitive management. Spinal dose steroids. Several studies have investigated the use of methylprednisolone in acute spinal cord injury. The National Acute Spinal Cord Injury Studies, NACIS 1, 2, and 2, provided some support for the view that administration of high-dose methylprednisolone in acute spinal cord injury results in improved neurologic outcomes. A post hoc analysis performed as part of NACIS II demonstrated improved neurologic outcomes if methylprednisolone was administered within 8 hours of injury. A post hoc analysis in NACIS III showed improved outcomes at 6 weeks and 6 months, but not 1 year when methylprednisolone was administered within 3 and 8 hours of injury. However, these findings are tempered by the fact that these benefits were modest and only demonstrated in post hoc analyses, and by the high rate of medical complications associated with corticosteroid administration. All 3 NACIS trials showed that methylprednisolone was associated with a higher rate of complications such as pneumonia, severe sepsis, and poor wound healing. A recent Cochrane review did not observe a significant increase in complications or mortality associated with methylprednisolone administration in acute spinal cord injury, but did observe a trend towards this effect. Despite the lack of clear evidence on this issue, the most recent acute spinal cord injury guidelines provide a controversial level I recommendation against the use of corticosteroids in acute spinal cord injury. Some authors have argued for the use of methylprednisolone within 8 hours of acute spinal cord injury in carefully selected patients, e.g., young males that are less prone to medical complications associated with corticosteroids. Thus, clear consensus on the use of spinal dose steroids does not exist. A decision to use or not use spinal dose steroids may be dictated by local or regional practice patterns, especially given the legal liability issues surrounding SCI. Patients with gunshot or nerve root cauda equina injuries, or those who are pregnant less than 14 years old or on chronic steroids, were excluded from the NASCA studies and should not receive spinal dose steroids. In addition to steroids, hypothermia for SCI has also received attention. There is even less evidence supporting the use of this treatment, and thus it is not currently recommended. Orthotic devices, rigid external orthotic devices, can stabilize the spine by decreasing range of motion and minimizing stress transmitted through the spine. Commonly used rigid cervical orthoses include Philadelphia and Miami J collars. Cervical collars are inadequate for C1, C2, or cervicothoracic instability. Cervicothoracic orthoses brace the upper thorax and the neck, improving stabilization over the cervicothoracic region. Minerva braces improve high cervical stabilization by bracing from the upper thorax to the chin and occiput. Halo vest assemblies provide the most external cervical stabilization. 4 pins are driven into the skull to lock the halo ring in position. 4 posts arising from a tight-fitting rigid plastic vest immobilize the halo ring. Lumbar stabilization may be provided by thoracolumbo-sacral orthoses. A variety of companies manufacture lines of spinal orthotics. A physician familiar with the technique should fit a halo vest. Assistance from a trained orthotics technician improves fitting and adjustment of the other devices. Surgery neurosurgical intervention has 2 goals: decompression of the spinal cord and nerve roots, and stabilization of the spine. When spinal cord injury is caused by a hyperflexion distraction injury that results in cord compression and an unstable spine, both surgical decompression and fusion are typically required. However, in cases of a hyperextension injury causing central cord syndrome due to chronic cervical stenosis, surgical decompression may be needed without the need for internal fixation. In cases where there's significant anterolisthesis, subaxial cervical jumped or perched facets, reduction of the fracture may be important for both decompression and stabilization. However, in some cases, reduction of the fracture may not be sufficient for decompression, and further decompressive surgery may still be needed. Several controversial topics require consideration here. First, the timing of surgery has been a controversial topic. In the past, it has been suggested that patients with incomplete injury or a deteriorating exam warrant emergent decompression, whereas patients with complete injuries can undergo surgery in a non-emergent manner. It is important to appreciate the risks of taking a medically unstable patient to surgery, such as a polytrauma patient with hemorrhagic shock or a complete spinal cord injury patient in neurogenic shock. However, there are clear benefits to early surgical decompression. It can allow early mobilization, aggressive nursing care, and physical therapy. Furthermore, a recent prospective cohort study found that the odds of observing a 2-point increase in Asia grade at 6 months was higher in patients that underwent surgery within 24 hours, as compared to those that underwent surgery after 24 hours. These data suggest that a subpopulation of patients may significantly benefit from early surgery. However, the characteristics of these patients were not described, suggesting a heterogeneous population in terms of preoperative Asia grade and imaging in general. Spine trauma patients with complete neurologic deficit without any signs of recovery, or those without any neurologic deficits who have bony or ligamentous injury requiring open fixation, may be medically stabilized before undergoing surgery. Surgical stabilization may be indicated for some injuries that would eventually heal with conservative treatment. Solid surgical stabilization may also allow a patient to be managed with a rigid cervical collar who would otherwise require halo vest immobilization. Continued care. Regional SCI centers with nurses, respiratory therapists, pulmonologists, physical therapists, physiatrists, and neurosurgeons specifically trained in caring for these patients may improve outcomes. Frequently encountered ICU issues include hypotension due to neurogenic shock due to loss of sympathetic tone and aspiration pneumonia. The recent guidelines recommend maintaining MAPS greater than 85 for 7 days after injury. Chronically, prevention and treatment of deep venous thrombosis, autonomic hyperreflexia, and decubitus ulcer formation are important. Many patients with cervical or high thoracic cord injuries require prolonged ventilatory support until the chest wall becomes stiff enough to provide resistance for diaphragmatic breathing. Patients with high cervical cord injuries, C4 or above, will often require permanent ventilatory support. Patients should be transferred to SCI rehabilitation centers after stabilization of medical and surgical issues. Peripheral nerve trauma. The peripheral nervous system extends throughout the body and is subject to injury from a wide variety of trauma. Peripheral nerves transmit motor sensory information from the CNS to the body. An individual nerve may have pure motor, pure sensory, or mixed motor and sensory functions. The key information-carrying structure of the nerve is the axon. The axon transmits information from the neuronal cell body and may measure from less than 1 millimeter to greater than 1 minute in length. Axons that travel a significant distance are often covered with myelin, which is a lipid-rich, electrically insulating sheath formed by Schwann cells. Myelinated axons transmit signals much more rapidly than unmyelinated axons because the voltage shifts and currents that define action potentials effectively jump from gap to gap over the insulated lengths of the axon. Axons, whether myelinated or unmyelinated, travel through a collagenous connective tissue known as endoneurium. Groups of axons and their endoneurium form bundles known as fascicles. Fascicles run through a tubular collagenous tissue known as perineurium. Groups of fascicles are suspended in mesoneurium. Fascicles and their mesoneurium run through another tubular collagenous tissue known as epineurium. The epineurium and its contents form the nerve. There are 4 major mechanisms of injury to peripheral nerves. Their nerves may be lacerated, stretched, compressed, or contused. Knives, passing bullets, or jagged bone fractures may lacerate nerves. Adjacent expanding hematomas or dislocated fractures may stretch nerves. Expanding hematomas, external orthoses such as casts or braces, or blunt trauma over a superficial nerve may compress or crush nerves. Shock waves from high-velocity bullets may contuse nerves. These mechanisms of injury cause damage to the various anatomic components of the nerve. The patterns of damage are categorized in types of injury. Certain nerve segments are particularly vulnerable to injury. The following 4 characteristics make a nerve segment more vulnerable: proximity to a joint superficial course, passage through a confined space, and being fixed in position. Types of injury. The traditional classification system for peripheral nerve injury is the Seddon classification. Seddon described 3 injury patterns as defined in the neuropraxia, axonotmesis, and neurotmesis sections. The Seddon classification provides a simple, anatomically based approach to peripheral nerve injury. Neuropraxia. Neuropraxia is defined as the temporary failure of nerve function without physical axonal disruption. Axon degeneration does not occur. Return of normal axonal function occurs over hours to months, often in the 2 to 4 week range. Axonotmesis. Axonotmesis is the disruption of axons and myelin. The surrounding connective tissues, including endoneurium, are intact. The axons degenerate proximally and distally from the area of injury. Distal degeneration is known as Wallerian degeneration. Axon regeneration within the connective tissue pathways can occur, leading to restoration of function. Axons regenerate at a rate of 1 millimeter per day. Significant functional recovery may occur for up to 18 months. Scarring at the site of injury from connective tissue reaction can form a neuroma and interfere with regeneration. Neurotemesis. Neurotemesis is the disruption of axons and endoneurial tubes. Peripheral collagenous components, such as the epineurium, may or may not be intact. Proximal and distal axonal degeneration occurs. The likelihood of effective axonal regeneration across the site of injury depends on the extent of neuroma formation and on the degree of persisting anatomic alignment of the connective tissue structures. For instance, an injury may damage axons, myelin, and endoneurium, but leave perineurium intact. In this case, the fascicle sheath is intact, and appropriate axonal regeneration is more likely to occur than if the sheath is interrupted. Management of peripheral nerve injury. The sensory and motor deficits should be accurately documented. Deficits are usually immediate. Progressive deficits suggest a process such as an expanding hematoma and may warrant early surgical exploration. Clean, sharp injuries may also benefit from early exploration and reanastomosis. Most other peripheral nerve injuries should be observed. EMG NCS studies should be done 3 to 6 weeks post-injury if deficits persist. Axon segments distal to the site of injury will conduct action potentials normally until Wallerian degeneration occurs, rendering EMG NCS before 3 weeks uninformative. Continued observation is indicated if function improves. Surgical exploration of the nerve may be undertaken if no functional improvement occurs over 3 months. If intraoperative electrical testing reveals conduction across the injury, continue observation. In the absence of conduction, the injured segment should be resected and end-to-end primary anastomosis attempted. However, anastomosis under tension will not heal. A nerve graft may be needed to bridge the gap between the proximal and distal nerve ends. The sural nerve often is harvested as it carries only sensory fibers and leaves a minor deficit when resected. The connective tissue structures of the nerve graft may provide a pathway for effective axonal regrowth across the injury. Patterns of injury. Brachial plexus. The brachial plexus may be injured in a variety of ways. Parturition or a motorcycle accident can lead to plexus injury due to dislocation of the glenohumeral joint. Attempting to arrest a fall with one's hands can lead to a stretch injury of the plexus due to abrupt movement of the shoulder girdle. An apical lung pancreas tumor can cause compression injury to the plexus. There are many patterns of neurologic deficits possible with injury to the various components of the brachial plexus, and understanding them all would require extensive neuroanatomic discussion. Two well-known eponymous syndromes are Erb's palsy and Klumpke's palsy. Injury high in the plexus to the C5 and C6 roots resulting from glenohumeral dislocation causes Erb's palsy with the characteristic bellhop's tip. Position. The arm hangs at the side, internally rotated, hand movements are not affected. Injury low in the plexus to the C8 and T1 roots, resulting from stretch or compression injury, causes Klumpke's palsy with the characteristic claw hand deformity. There is weakness of the intrinsic hand muscle, similar to that seen with ulnar nerve injury. Radial nerve. The radial nerve courses through the axilla, then laterally and posteriorly in the spiral groove of the humerus. Improper crutch use can cause damage to the axillary portion. The section of the nerve traversing the spiral groove can be damaged by humerus fractures or pressure from improper positioning during sleep. This classically occurs when the patient is intoxicated and is called Saturday night palsy. The key finding is wrist drop, i.e., weakness of hand and finger extensors. Axillary proximal injury causes triceps weakness in addition to wrist drop. Common peroneal neuropathy. The common peroneal nerve forms the lateral half of the sciatic nerve, the medial half being the tibial nerve. It receives contributions from L4, L5, S1, and S2. It emerges as a separate nerve in a popliteal fossa and laterally wraps around the fibular neck, after which it splits to form the deep and superficial peroneal nerves. The superficial fixed location at the fibular neck makes the common peroneal nerve susceptible to compression. The classic cause of traumatic peroneal neuropathy is crush injury from a car bumper striking the lateral aspect of the leg at the knee. Symptoms of common peroneal neuropathy include foot drop, weakness of the tibialis anterior, eversion weakness and numbness over the anterolateral surface of the lower leg and dorsum of the foot. In contrast, a foot drop due to L5 radiculopathy spares eversion because the S1 fibers are intact. Surgical exploration of a common peroneal crush lesion is typically a low-yield endeavor. Rare cases may be due to compressive fibers or adhesions that may be lysed with the possibility of return of function. Cerebrovascular disease. Cerebrovascular disease is the most frequent cause of new, rapid onset, non-traumatic neurologic deficit. It is far more common than seizures or tumors. Vascular structures are subject to a variety of chronic pathologic processes that compromise vessel wall integrity. Diabetes, high cholesterol, high blood pressure, and smoking, common comorbidities in the general population, are important risk factors for vascular disease. These conditions can lead to vascular damage by such mechanisms as atheroma deposition causing luminal stenosis, endothelial damage promoting thrombogenesis, and weakening of the vessel wall resulting in aneurysm formation or dissection. These processes may coexist. For instance, a vessel containing an atheromatous plaque will have a decreased luminal diameter. The plaque also may have compromised endothelium, providing the opportunity for thrombus formation, which can lead to acute total occlusion of the remaining lumen. Aneurysms and dissection often occur in atheromatous vessels. Specific patterns of disease relevant to the cerebrovascular system include atheromatous and thrombotic carotid occlusion, brain ischemia from proximal embolic disease, vessel wall rupture leading to hemorrhage, and rupture of abnormal thin-walled structures, specifically aneurysms and AVMs. Ischemic diseases. Ischemic stroke accounts for approximately 85% of acute cerebrovascular events. Symptoms of acute ischemic stroke vary based on the functions of the neural tissues supplied by the occluded vessel and the presence or absence of collateral circulation. The circle of Willis provides extensive collateral circulation as it connects the right and left carotid arteries to each other and each to the vertebrobasilar system. Patients with complete occlusion of the carotid artery proximal to the circle of Willis may be asymptomatic if the blood flow patterns can shift and provide sufficient circulation to the ipsilateral cerebral hemisphere from the contralateral carotid and the basilar artery. However, the anatomy of the circle of Willis is highly variable. Patients may have a congenitally hypoplastic or missing communicating artery with resultant bilateral ACA supply by one carotid, or the PCA may be supplied by the carotid artery rather than the basilar. Similarly, one vertebral artery is often dominant and the other is hypoplastic. These variations may make disease in a particular vessel more neurologically devastating than in a patient with full collateral circulation. Occlusion distal to the circle of Willis generally results in a stroke in the territory supplied by that particular artery. Neurologic deficit from occlusive disease may be temporary or permanent. A patient with sudden onset focal neurologic deficit that resolves within 24 hours has had a transient ischemic attack, TIA. A patient with permanent deficit has had a completed stroke, thrombotic disease. The most common area of neurologically significant vessel thrombosis is the carotid artery in the neck. Disease occurs at the carotid bifurcation. Thrombosis of a carotid artery chronically narrowed by atheroma can lead to acute carotid occlusion. As discussed previously, this can be asymptomatic due to sufficient collateralization. The more common concern is thromboembolus. Intracranial arterial occlusion by local thrombus formation may occur, but it is rare compared to embolic occlusion. Management. Complete occlusion of the carotid artery without referable neurologic deficit requires no treatment. A patient with new neurologic deficit and an angiographically confirmed complete carotid occlusion contralateral to the symptoms should be considered for emergent carotid endarterectomy. Surgery should be performed within 2 hours of symptom onset and should not be performed on obtunded or comatose patients. These restrictions significantly reduce the number of operative candidates. In non-emergent cases, the results of the largest-scale North American symptomatic carotid stenosis trial NASCET demonstrated a stroke reduction benefit to surgical revascularization in patients with severe stenosis, defined as occlusion of 70% to 99% of the carotid. Practice guidelines recommend revascularization at this level of stenosis, even if asymptomatic. Surgical options for these patients include both carotid endarterectomy and carotid stenting, which have been shown to produce equal outcomes over long-term follow-up. Embolic disease. Emboli-causing strokes may originate from a number of sources, including the left atrium and atrial fibrillation, a hypokinetic left ventricular wall segment, valvular vegetations, and atheromatous aortic arch, stenotic atheromatous carotid bifurcations, or from the systemic venous system in the presence of a right-to-left shunt, such as a patent foramen ovale. The majority of emboli enter the anterior carotid circulation rather than the posterior vertebrobasilar circulation. Characteristic clinical syndromes result from embolic occlusion of various vessels within these circulations. Common types of strokes: anterior cerebral artery stroke. The ACA supplies the medial, frontal, and parietal lobes as it courses into the interhemispheric fissure. Due to its vascular supply of the motor cortex, ACA stroke characteristically results in contralateral leg weakness. Middle cerebral artery stroke. The MCA supplies the lateral frontal and parietal lobes and the temporal lobe. MCA stroke results in contralateral face and arm weakness. Dominant hemisphere MCA stroke causes language deficits due to its supply of Broca's area, Wernicke's area, and the white matter tracts that connect the two. Proximal MCA occlusion with ischemia and swelling in the entire MCA territory can lead to significant intracranial mass effect and midline shift. See figure 42.6, termed malignant MCA stroke. Posterior cerebral artery stroke. The PCA supplies the occipital lobe. PCA stroke results in a contralateral homonymous hemianopsia. See figure 42.6. Posterior inferior cerebellar artery stroke. The PICA supplies the lateral medulla and the inferior half of the cerebellar. 1850. Mus dysphagia. Ipsilateral mus dysphagia. Ipsilateral Horner syndrome and ipsilateral limb ataxia. The constellation of symptoms resulting from PICA occlusion is referred to as the lateral medullary or Wallenberg syndrome. Management. Ischemic stroke management has two goals: reopen the occluded vessel and maintain blood flow to ischemic penumbra tissues bordering the vascular territory. Reopening the vessel has historically been attempted with recombinant TPA. TPA administration within 3 hours of the onset of neurologic deficit improves outcome at 3 months. In the setting of suspected ischemic stroke, a head CT must be performed immediately to differentiate ischemic from hemorrhagic stroke. Intracranial hemorrhage, major surgery within the previous 2 weeks, GI or genitourinary hemorrhage in the previous 3 weeks, platelet count less than 100,000, and systolic blood pressure greater than 185 mmHg are among the contraindications to TPA therapy. In recent years, a paradigm shift in ischemic stroke management has occurred with the advent of endovascular mechanical thrombectomy. Though TPA can be effective for strokes of smaller vessels, it produces recanalization in only 20% of large vessel ischemic strokes, and even less for internal carotid artery occlusion. In mechanical thrombectomy, the intracranial circulation is accessed endovascularly, and stent retriever devices can be deployed to definitively remove clot and stent open involved vessels. Initial investigations into the technology began in 1999 with varied success. Technological advances proceeded, and in 2015, large-scale clinical trials investigating mechanical thrombectomy for large vessel occlusion were published. The Mr. Clean trial was one of these. In this trial, 500 patients were randomized to TPA and medical therapy against mechanical thrombectomy. The latter group had a significantly better 90-day outcome. A domino effect ensued in which 4 other similarly large-scale trials e.g. Rivascat F8, were terminated early. Benefits to mechanical thrombectomy include less stringent criteria than TPA administration, focused therapy, and time windows between 6 and 12 hours in trials. Currently, mechanical thrombectomy is being used for large vessel occlusion within 6 hours of symptom onset for those patients not eligible for TPA, which accounts for about 10% of ischemic stroke. Its indications and associated technology continue to evolve. It should be noted that current guidelines still support TPA as first-line therapy, even for those eligible for mechanical thrombectomy. Patients not eligible for TPA or mechanical thrombectomy require hemodynamic optimization and neurologic monitoring. Admit such patients to the ICU stroke service for blood pressure management and frequent neurologic checks. Permissive hypertension allows for maximal cerebral perfusion. Systolic blood pressure greater than 180 mmHg may require treatment, but the optimal mean arterial pressure goal is between 100 and 140 mmHg. Give normal saline solution without glucose, which could injure neurons in the penumbra due to osmotic fluid shift, and aim for normovolemia. A stroke patient who worsens clinically should undergo repeat head CT to evaluate for hemorrhage or increasing mass effect from swelling, which typically peaks 3 to 5 days after the stroke. Significant swelling from an MCA or cerebellar stroke may cause herniation and brainstem injury. A decompressive hemicraniectomy or suboccipital craniectomy can be a life-saving intervention for these select stroke patients. In studies of malignant MCA syndrome, decompressive hemicraniectomy showed favorable mortality and functional outcomes. This treatment option, however, should be considered with the understanding of potentially poor functional recovery regardless of therapy. One study showed that less than half of malignant MCA patients who underwent decompressive hemicraniectomy returned home following rehabilitation, which is even fewer for those undergoing medical therapy. Hemorrhagic diseases. Intracranial hemorrhage from abnormal or diseased vascular structures accounts for approximately 15% of acute cerebrovascular events. Hypertension and amyloid angiopathy account for most intraparenchymal hemorrhages, although AVMs, aneurysms, venous thrombosis, tumors, hemorrhagic conversion of ischemic infarct, and fungal infections also may be the cause. The term intracranial hemorrhage is frequently used to signify intraparenchymal hemorrhage and will be used here. Intracranial hemorrhage causes local neuronal injury and dysfunction, and also may cause global dysfunction due to mass effect if sufficiently large. The Intracerebral Hemorrhage Act score is commonly used to risk stratify these patients, and it takes into account GCS, age, hemorrhage volume, presence of intraventricular hemorrhage, and location to predict mortality. AVM or aneurysm rupture along with trauma discussed previously in this chapter result in subarachnoid hemorrhage, SA, because the major cerebral and cortical blood vessels travel in the subarachnoid space between the PI and the arachnoid membranes. SA can cause immediate concussive-like neuronal dysfunction by exposure of the brain to intra-arterial pressure pulsations during the hemorrhage. Moreover, it can cause delayed ischemia from cerebral arterial vasospasm, which can present as acute worsening of the patient's neurological status, days to weeks after the injury. Patients presenting with intracranial hemorrhages that do not follow typical patterns should undergo cerebral angiography or MRI to evaluate for possible underlying lesions, such as AVM or tumor. Hemorrhagic stroke most commonly occurs within the basal ganglia or cerebellum. The patient is usually hypertensive on admission and has a history of poorly controlled hypertension. Such patients are more likely to present with lethargy or obtundation compared to those who suffer an ischemic stroke. Depressed mental status results from mass effect from the hematoma in deep structures, which can produce midline shift or herniation. Ischemic stroke does not cause mass effect acutely. Therefore, patients are more likely to present with normal consciousness and a focal neurologic deficit. Hemorrhagic strokes tend to present with a relatively gradual decline in neurologic function as the hematoma expands, rather than the immediately maximal symptoms caused by ischemic stroke. Table 42-3 provides a listing of relative incidences of intracranial hemorrhage by anatomic distribution. Hypertension. Hypertension increases the relative risk of intracranial hemorrhage by approximately fourfold, likely due to chronic degenerative vasculopathy. Hypertensive hemorrhage is often present in the basal ganglia, thalamus, or pons, and result from breakage of small perforating arteries that branch off of much larger parent vessels, figure 42-16. Most hypertensive hemorrhages should be medically managed. The hematoma often contains intact, salvageable axons because the blood dissects through and along neural tracts, and surgical clot evacuation destroys these axons. Factors potentially favoring surgery include superficial clot location, young age, non-dominant hemisphere, rapid deterioration, and significant. Table 42-3, mass effect. However, the most comprehensive randomized clinical trials to date did not show an overall improved outcome in surgically evacuated intracranial hemorrhage. except for the subgroup of patients with clot less than 1 centimeter from the cortical surface. More recent studies have assessed the role of minimally invasive catheter evacuation of clot. These investigations are ongoing. Medical management remains the gold standard, however, and includes moderate blood pressure control, normalizing platelet and clotting function, phenytoin or levetiracetam for seizure prophylaxis, and electrolyte management. Intubate patients who cannot clearly follow commands to prevent aspiration and hypercarbia. Follow and document the neurologic examination, and communicate with the family regarding appropriateness for rehabilitation against withdrawal of care. Amyloid angiopathy. The presence of pathologic amyloid deposition in the media of small cortical vessels compromises vessel integrity and tends to cause more superficial lobar hemorrhages than hypertensive intracranial. Hemorrhage. Amyloid-laden vessels may hemorrhage multiple times. The superficial location of amyloid hemorrhages may make surgical evacuation less morbid compared to typical deep hypertensive hemorrhages. Nonetheless, medical management and family counseling should be approached similarly to patients with hypertensive hemorrhages. Table 42-4, prevalence of cerebral aneurysm by location. Cerebral aneurysm. An aneurysm is a focal dilatation of the vessel wall and is most often a balloon-like outpouching, but may also be fusiform. Aneurysms usually occur at branch points of major vessels, e.g., internal carotid artery bifurcation, or at the origin of smaller vessels, e.g., posterior communicating artery or ophthalmic artery. Approximately 85% of aneurysms arise from the anterior circulation carotid and 15% from the posterior circulation vertebrobasilar. Table 42-4 shows the percentage distribution of cerebral aneurysms by location. Aneurysms are thin-walled and at risk for rupture. The major cerebral vessels, and therefore aneurysms, lie in the subarachnoid space. Rupture results in SA. The aneurysmal tear may be small and seal quickly, or it may not. SA may consist of a thin layer of blood in the CSF spaces, or thick layers of blood around the brain and extending into brain parenchyma, resulting in a clot with mass effect. Because the meningeal linings of the brain are sensitive with free nerve endings, SA usually results in a sudden severe thunderclap headache. A patient will classically describe the worst headache of my life. Presenting neurologic symptoms may range from mild headache to coma to sudden death. The Hunt-Hess grading system categorizes patients clinically. Table 42-5. Table 42-5. The Hunt-Hess clinical grading system for subarachnoid hemorrhage. Figure 42-17. Non-contrast CT scan on the left shows diffuse subarachnoid blood in the cisterns with some concentration in the region of the anterior cerebral arteries. This is confirmed by the image on the right, a CT angiogram, where the arrow indicates an anterior communicating artery aneurysm. The World Federation of Neurological Surgery WFNS-SH grading scale is also used for this purpose. The Fisher scale and a more recent modified form use head CT characteristics described in the following section to stratify patients based on risk of vasospasm-induced delayed cerebral ischemia. Both scales are used in conjunction as a quick way to communicate severity of aneurysmal SA. Patients with symptoms suspicious for SA should have a head CT immediately. Acute SA appears as a bright signal in the fissures and CSF cisterns around the base of the brain, as shown in figure 42-17. CT is rapid, non-invasive, and approximately 95% sensitive. In patients with suspicious symptoms but negative head CT, a lumbar puncture LP should be performed. An LP with xanthochromia and high red blood cell counts, usually 100,000 ml, which do not decrease between tubes 1 and 4, is consistent with SAH. Negative CT and LP essentially rules out SAH. Patients diagnosed with SAH require 4 vessel cerebral angiography within 24 hours to assess for aneurysm or other vascular malformation. Catheter angiography remains the gold standard for assessing the patient's cerebral vasculature, relevant anomalies, and presence, location, and morphology of the cerebral aneurysms. Figure 42-18A demonstrates the typical anteroposterior digital subtraction angiographic view of a cerebral aneurysm. Figure 42-18B shows the anatomy of the circle of Willis in a simplified graphic representation to assist in visualizing the locations of various cerebral aneurysms. SAH patients should be admitted to the neurologic ICU. Hunt-Hess grade 4 and 5 patients require intubation and hemodynamic monitoring and stabilization. The current standard of care for ruptured aneurysms requires early aneurysmal occlusion. There are 2 options for occlusion. The patient may undergo craniotomy with microsurgical dissection and placement of a titanium clip across the aneurysm neck to exclude the aneurysm from the circulation and reconstitute the lumen of the parent vessel. The second option is to utilize an endovascular approach for treatment, which has traditionally taken the form of coiling. The patient is taken to the interventional neuroradiology suite for placement of looped titanium coils inside the aneurysm dome. The coils support thrombosis and prevent intracranial aneurysms. Figure 42-18. A anteroposterior view after injection of contrast blood flow into the aneurysm. Newer endovascular options include flow diversion and stent-assisted coiling. Factors favoring craniotomy and clipping include young age, good medical condition, and broad aneurysm necks. Factors favoring coiling include age, medical comorbidities, and narrow aneurysm necks. Due to coil migration or compaction over time, surgical clipping is believed to result in a more definitive cure. The decision to clip or coil is complex and should be fully explored. Practice standards have changed in recent years with the advent of more nuanced endovascular techniques and treatment options, as described earlier. Current guidelines favor endovascular therapy as the preferred first-line approach. The International Subarachnoid Aneurysm Trial researchers suggested that endovascular occlusion resulted in better mortality outcomes for certain types of cerebral aneurysms. Although this trial was marred by poor selection and randomization techniques, and the validity of its conclusions have been questioned. Long-term outcomes may be better in younger patients with clipped aneurysms, as demonstrated in the Barrow Ruptured Aneurysm Trial BRAT. However, this trial has a number of similar criticisms as well. Debate also continues regarding optimal care for unruptured intracranial aneurysms, with a recent large-scale study showing no clear benefit to open surgical against endovascular approaches. SHA patients often require 1 to 3 weeks of ICU care after aneurysm occlusion for medical complications that accompany neurologic injury. In addition to routine ICU concerns, SH patients are also at risk for cerebral vasospasm. In vasospasm, cerebral arteries constrict pathologically and can cause ischemia or stroke from 4 to 21 days after SOP. Current vasospasm prophylaxis includes maintenance of optimal perfusion with hypertension and mild hypervolemia, as well as administration of nimodipine, a calcium channel blocker that may decrease the incidence and degree of spasm, though its mechanism is debated. Neurointerventional options for treating symptomatic vasospasm include intra-arterial paparine or nicardipine and balloon angioplasty for larger caliber vessels. Aneurysmal SAH has an approximate mortality rate of 50% in the first month. Approximately 1/3 of survivors return to PRE-SAH function, and the remaining T2/3-4 have mild to severe disability. Most require rehabilitation after hospitalization. Arteriovenous malformations. AVMs are abnormal, dilated arteries and veins without an intervening capillary bed. The nidus of the AVM contains a tangled mass of vessels, but no neural tissue. AVMs may be asymptomatic or present with SAH, intraparenchymal hemorrhage or seizures. Small AVMs present with hemorrhage more often than large AVMs, which tend to present with seizures. Headache, bruit, or focal neurologic deficits are less common symptoms. AVMs hemorrhage at an average rate of 0% to 4% a year. Figure 42 to 19 demonstrates the angiographic appearance of an AVM in arterial and venous phases. For unruptured AVMs, recent evidence from over 200 patients supports medical management alone rather than intervention due to risk of stroke. Because AVM rupture can present radiographically as SAH, it is important to consider several management differences as compared to aneurysmal SAH. Definitive therapy for the AVM usually is delayed 3 to 4 weeks to allow the brain to recover from acute injury. There is less risk of devastating early rebleeding from AVMs, and vasospasm is much less common. 3 therapeutic modalities for AVMs are currently in common use: microsurgical excision, interventional radiology or endovascular embolization, and stereotactic radiosurgery SRS. AVMs that are large, near eloquent cortex, or that drain to deep venous structures are considered high grade and more difficult to surgically resect without causing a significant neurologic deficit. Radiosurgery can treat these lesions, although it is limited to lesions less than 3 centimeters in diameter and has a 2-year lag time. The AVM may bleed in the interval. Embolization reduces flow through the AVM. 2 is usually considered adjunctive therapy, but it may serve as the sole treatment for deep, inaccessible lesions. Artery, MCA equal to middle cerebral artery, tumors of the central nervous system. A wide variety of tumors affect the brain and spine. Primary benign and malignant tumors arise from the various elements of the CNS, including neurons, glia, and meninges. Tumors medicine. TON varies widely depending on relevant neuroanatomy. Prognosis depends on histology and anatomy. Modern brain tumor centers use team approaches to CNS tumors, as patients may require a combination of surgery, including newer, more minimally invasive approaches, radiation therapy, chemotherapy, SRS, and research protocol enrollment for studies assessing the efficacy of newer approaches such as immunotherapy. Tumors affecting the peripheral nervous system are discussed in the peripheral nerve section. Intracranial tumors. Intracranial tumors can cause brain injury from mass effect, dysfunction, or destruction of adjacent neural structures, swelling, or abnormal electrical activity seizures. Supratentorial tumors commonly present with focal neurologic deficit, such as contralateral limb weakness, visual field deficit, headache, or seizure. Infratentorial tumors often cause increased ICP due to hydrocephalus from compression of the fourth ventricle, leading to headache, nausea, vomiting, or diplopia. Cerebellar hemisphere or brainstem dysfunction can result in ataxia, nystagmus, or cranial nerve palsies. Infratentorial tumors rarely cause seizures. All patients with symptoms concerning for brain tumors should undergo MRI with and without gadolinium. Gadolinium-based contrast can identify locations of blood-brain barrier breakdown of tumors and, when used in conjunction with other MRI sequences, is essential in narrowing the differential diagnosis. Initial management of a patient with a symptomatic brain tumor generally includes dexamethasone for reduction of vasogenic edema and phenytoin or levetiracetam if the patient is seized. Patients with significant weakness, lethargy, or hydrocephalus should be admitted for observation until definitive care is administered. Metastatic tumors. Cerebral metastases are the most common type of intracranial tumor. Prolonged cancer patient survival and improved CNS imaging have increased the likelihood of diagnosing cerebral metastases. The sources of most cerebral metastases are in decreasing frequency: lung, breast, kidney, GI tract, and melanoma. Lung and breast cancers account for more than half of cerebral metastases. Metastatic cells usually travel to the brain hematogenously and frequently seed the gray-white junction due to characteristic blood vessel caliber change. Other common locations are the cerebellum and the meninges. Meningeal involvement may result in carcinomatous meningitis, also known as leptomeningeal carcinomatosis. MRI, pre- and post-contrast administration, is the study of choice for evaluation. Figure 42-20 demonstrates bilateral cerebellar metastases. These lesions are typically well circumscribed, round, and multiple. Such findings should prompt a metastatic workup, including CT scan of the chest, abdomen, and pelvis, and a bone scan. Management largely depends upon the primary tumor, overall tumor burden, patient's medical condition, and location and number of metastases. The beliefs of the patient and family regarding aggressive care must be considered, with the primary goal of optimizing survival time while maintaining or improving neurological function. Neurosurgical intervention can be indicated for a number of reasons. Biopsy can be obtained to provide a tissue diagnosis and further direct therapy. Hydrocephalus from increased intracranial pressure due to intracranial tumor burden can be temporized via placement of a ventriculoperitoneal shunt. Craniotomy can be used for debulking of intracranial tumor burden or resection. Data from randomized controlled trials have supported the use of craniotomy for tumor resection plus whole brain radiation therapy, WBRT, or stereotactic radiosurgery, SRS, for patients with a single surgically accessible metastatic lesion compared to radiation therapy alone. In one randomized trial assessing surgery and WBRT against WBRT alone, local recurrence decreased in median, and displacing the brainstem to the right, survival increased from 15 to 40 weeks. For multiple metastases, it should be noted that craniotomy primarily for resection is typically not indicated unless all detectable metastases can be resected. It may, however, still be useful for symptomatic relief from a primary lesion. Recent data suggests that SRS, for example, gamma knife, may be applied to multiple metastases in one session with improved outcome. Glial tumors. Glial cells provide the anatomic and physiologic support for neurons and their processes in the brain. Tumors arising from glial cells are termed gliomas, and they represent the most common primary brain tumor. The several types of glial cells give rise to distinct primary CNS neoplasms. Astrocytoma. Astrocytoma is the most common primary CNS neoplasm. The term glioma often is used to refer to astrocytomas specifically, excluding other glial tumors. Astrocytomas are graded from I to fourth grades. 1 and 2 are referred to as low-grade astrocytoma or low-grade glioma. Grade 3 is anaplastic astrocytoma, and grade 4 is glioblastoma multiforme, GBM. Prognosis varies significantly between grades I, I2, and IV, but not between I and second. Median survival is 8 years after diagnosis with a low-grade tumor, 2 to 3 years with an anaplastic astrocytoma, and roughly 1 year with a GBM. GBMs account for almost 2/3 of all astrocytomas. Anaplastic astrocytomas account for 2/3 of the rest, and low-grade astrocytomas the remainder. Figure 42-21 demonstrates the typical appearance of a GBM. The great majority of astrocytomas infiltrate adjacent brain. Juvenile palicytic astrocytomas and pleomorphic xanthoastrocytomas are exceptions. These tumors are circumscribed, low-grade, and associated with a good prognosis. Histologic features associated with higher grade include hypercellularity, nuclear atypia, and endovascular hyperplasia. Necrosis is present only with GBMs. It is required for the diagnosis. Gross total resection should be attempted for suspected astrocytomas. Motor cortex, language centers, deep or midline structures, or brainstem location may make this impossible without unacceptable, devastating neurologic deficit. Advanced imaging such as diffusion tensor imaging, DTI, and functional MRI, fMRI, are seeing increased use as means of assessing peritumoral structure and function to guide surgical decision-making. However, some lesions may be in such precarious regions as to be limited to stereotactic needle biopsy specimen. Gross total resection followed by fraction radiotherapy, FRT, improves survival for all grades, although radiation therapy may be delayed until recurrence in low-grade tumors. Alongside FRT, adjuvant chemotherapy with temozolomide was demonstrated in a randomized controlled trial to increase short-term survival rate. Bevacizumab, an anti-VEGF antibody, is another treatment option under investigation. There are various ongoing research studies for GBM adjuvant therapy. These should be discussed with the patient and family. Other options include Iotrix-containing balloons for conformal radiation brachytherapy, Gliosite, placed in the resection cavity at the time of surgery for recurrence. Adjuvant therapy remains marginally effective. Survival has changed little over the last several decades. Oligodendroglioma. Oligodendroglioma accounts for approximately 10% of gliomas, arising from the oligodendrocytes that create myelin in the CNS. They often present with seizures. Calcifications and hemorrhage on CT or MRI suggest the diagnosis. Oligodendrogliomas are also graded from I to IV. Grade portends prognosis. Prognosis is better overall than for astrocytomas. Median survival ranges from 2 to 7 years for highest and lowest grade tumors, respectively. Aggressive resection improves survival. Many oligodendrogliomas will respond to procarbazine, lomustine CCNU, and vincristine PCV chemotherapy. A particular chromosomal deletion, 1P, has been associated with robust response to the chemotherapeutic agent temozolomide. Radiation has not been clearly shown to prolong survival. Recent updates to brain tumor classification by the WHO, discussed in the following section, note that high-grade at least 2 or 3 oligodendrogliomas and astrocytomas are classified together as diffuse gliomas. In fact, more similarity is seen between high-grade astrocytomas and oligodendrogliomas than between high-grade astrocytomas and low-grade astrocytomas. Further discussion of this nosology is beyond the scope of this chapter, but implications for the future of neuro-oncology are discussed here. Ependymoma. The lining of the ventricular system consists of cuboidal columnar ependymal cells from which ependymomas may arise. Although most pediatric ependymomas are supratentorial, 2/3 of adult ependymomas are infratentorial. Supratentorial ependymomas arise from the lateral or third ventricles. The infratentorial tumors arise from the floor of the fourth ventricle, i.e. off the posterior brainstem. The most common symptoms are headache, nausea, vomiting, or vertigo, secondary to increased ICP from obstruction of CSF flow through the fourth ventricle. The tumors may grow out the foramina of Luschka to form a cerebellopontine angle mass. They may also spread through the CSF to form drop mets in the spinal canal. The two main histologic subtypes are papillary and anaplastic, the latter characterized by increased mitotic activity in areas of necrosis. Gross total resection often is impossible because the tumor arises from the brainstem. The goal of surgery is to achieve maximal resection without injuring the very delicate brainstem. Suboccipital craniotomy and midline separation of the cerebellar hemispheres allows access to tumors in the fourth ventricle. Postoperative radiation therapy significantly improves survival. Patients with CSF spread documented by LP or contrast MRI should also have whole spine radiation plus focused doses to visualize metastases. Choroid plexus papilloma. The choroid plexus is composed of many small vascular tufts covered with cuboidal epithelium. It represents part of the interface between blood and brain. The choroid cells create CSF from blood via ultrafiltration and release it into the ventricular system. Choroid plexus papillomas and choroid plexus carcinomas, rare, mostly pediatric, may arise from these cells. Papillomas usually occur in infants, typically supratentorial in the lateral ventricle, but also occur in adults, usually infratentorial in the fourth ventricle. Papillomas are well circumscribed and vividly enhanced due to extensive vasculature. Like ependymomas, adult choroid plexus papillomas usually present with symptoms of increased ICP. Treatment is surgical excision. Total surgical excision is curative. Recurrent papillomas should be resected. Radiation and chemotherapy are not indicated for papillomas. Radiation is adjunctive to aggressive surgery for carcinomas, but the results are generally poor. Neural tumors and mixed tumors. Neural and mixed tumors are a diverse group that includes tumors variously containing normal or abnormal neurons and or normal or abnormal glial cells.